Uh, this session was supposed to start at 3:15. We are starting now. I thank the audience for staying back, number one. Number two, uh, these all these are cases which every cataract surgeon, every practitioner is going to face in his practice. The comorbid conditions that exist with cataract and how to manage it, what are the preferred practice patterns of managing. The first talk is going to be management of glaucoma and cataract, combined procedure by Dr. Sandhya Rajendra Prasad. She is the secretary of Bangalore Ophthalmic Society and a senior glaucoma consultant at Shaker Eye Hospital, Bangalore. Dr. Sandhya.
यहाँ पे खुली हुई है. Hello.
Yeah, go ahead.
Firstly, let me thank Dr. Lin. He's the president of the Bangalore Ophthalmic Society as well as AIOS to have given me this opportunity. I'll be talking about management of glaucoma and cataract in combined procedures. So why glaucoma and cataract? Because they commonly coexist in the older adults. You want to reduce the surgical burden. You also want to reduce the number of medications. You want an improvement of visual acuity and IOP control. Delayed presentations, advanced glaucomas, issues with compliance, lack of affordability, all of them demand combined surgeries in our country at least. Not moving. This is a few of the evidences which basically suggests that when you do a plain cataract surgery, you're reducing the IOP by 3 to 4 millimeters of mercury. However, adding a trabecular procedure provides the additional reduction in IOP, which is maintained even at 1 year, as well as shows a greater IOP production even beyond 1 year as well. Reduce post-operative medications use by almost 50% at the end of 1 year. When you combine phaco with trabeculectomy, which is the most commonly performed combined surgery when you talk about cataract and glaucoma alone, with all these, what you should remember is your target patients, who are going to be those with moderate to advanced glaucoma with visually significant cataracts. The evidence is here. This is a meta-analysis of 7 RCTs showing a greater IOP reduction of phaco-trab versus the phaco alone with reduced medications, concluding that phaco-trabeculectomy improves the pressure control compared with cataract surgery alone. Another meta-analysis of 10 studies, almost enrolling 3,108 patients, showed a significant IOP reduction and reduced dependence on glaucoma medications post-operatively. The reduction was almost 30 to 50% from baseline. The medications reduced by 1.5 to 2 times with a 5+ years of sustained IOP control. So the World Glaucoma Association actually endorses phaco-trab for moderate to advanced kind of glaucomas or uncontrolled IOPs. A small video of phaco-trab here. So I prefer to do a dual site surgery, starting off with my brittle suture, followed by a conjunctival opening. I use mitomycin C for all my procedures with a merosil sponge at the dose of 0.2 milligrams per ml. Wash it off. I do vary the concentration if it is a more advanced glaucoma or a neovascular uveitic glaucoma that I'm operating for. The shape and the size of your scleral flap is up to the individual surgeon, but I prefer a flap like you're seeing. I use number 11, number 15 blades, and I do a trapezoid kind of a flap. Once I have raised the flap to a good extent and can see my blue zone, this is followed by the cataract surgery. Important to note that the cataract surgery has to be uneventful in these kind of conditions. Very good rhexis, followed by a good hydrodissection, delineation. This is not a hard cataract, this is a simple cataract, whereas if you have a pseudo exfoliation, then you'll have the additional challenge of the zonules being very weak as well as the pupil which is not expanding. Once the cataract is completely removed, make sure that the IOL is in place. This is a 3-piece IOL that's going in. The visco wash will follow this. Make sure all the visco is actually out. This is revisiting my trap site, making sure I use a punch for an opening which is roughly 1 to 1.5 millimeters and a surgical PI. I prefer to close my trabeculectomy site with 3 sutures using a 10-0 nylon. I prefer 2 interrupted ones at the base and 1 at the apex, which I normally tend to use a releasable suture. But again, I do titrate it if I think that the patient is more young and it's a uveitic glaucoma and I would need the release of these sutures earlier. I prefer to go in using 2 releasable sutures because it's just more easy to titrate the same as against doing a suture lysis later. So once the releasable sutures, once a surgeon picks up how to put the releasable sutures, I think it's fairly easy to titrate it. Bleb management becomes much easier. This is followed by actually conjunctival suturing. Conjunctival sutures, I prefer to use vicryl suture for the conjunctiva, and I normally use wing sutures. Very few cases I follow it up with a central matrix suture as well. Important to note that you make sure that there is absolutely tight conjunctival closure at the end of the surgery. So next, coming to MIGS with phaco, which are coming up in a big way for us. The advantage of MIGS has always been conjunctival sparing as well as repeatability. Most commonly performed, one of the most commonly performed, the KDB goniotomy, 20 to 30% reduction with 1 to 1.5 fewer medications. Recovery is faster than trabeculectomy, less hypotony risk. This is a phaco goniotomy being performed. Phaco in the usual way. What you're seeing up here is your goniotomy, KDB. It has a sharp tip, it has a ramp, it has dual blades. Important to master the art of direct gonioscopy and use of the same under the microscope before you go into the procedures which involve usage of the direct gonioscope and the angle manipulations. For this, they are minimally invasive, they are repeatable, so that gives you the advantage over your conservative normal phacotrabeculectomy. After the IOL goes in, make sure the AC is well formed before you go in, so you can use a visco inside. You normally have to enter from the temporal side. What you're looking at is the nasal angle. About 90 to 110 degrees is the area in which you will cover the goniotomy. And when you're passing through this trabecular meshwork and the Schlemm's canal, sometimes you see this good reflux, a blood reflux, and that is actually good. It means your goniotomy is successful. Good to remember that the recovery time, though is longer in phacotrab, it is definitely more effective when compared to the goniotomy. The others are the hydrous microstent. You have the horizon randomized control trial, which is happening, 77% of them achieving more than 20% reduction as of now, and in 66% there is a medication-free period of almost 5 years. The GAT, which is being done quite often now for mild to moderate open angle glaucomas, steroid-induced glaucomas, juvenile open angle glaucomas, and patients requiring a combined procedure. Advantage is the same: the conjunctival sparing, physiological outflow restoration, and lower complication rates. This is a prospective study that gives a very good mean IOP reduction as well as reduction in the number of the drugs with a surgical success rate of almost 80%. This was a study published in the Indian Journal of Ophthalmology in 2025. As you see, a statistical significant IOP reduction post-operatively. So these are the basic parameters when you look at a phacotrab versus a phaco-MIGS. Remember that surgical invasiveness, though, is more with the phacotrab. It definitely has much more low IOP control. Long-term safety, as long as you can manage the bleb-related fibrosis, the shallow ACs, very rarely you will come up with endophthalmitis, you will be good to go. So you should basically know the bleb management very well. Whereas MIGS, you will have to master the art of MIGS. These are recent studies again showing that phacotrabeculectomy will be preferred when very low target IOP is required, whereas MIGS for mild to moderate glaucoma. A small thing about tube shunt surgery is only for refractory cases, failed traps, neovascular, uveitic glaucomas. The device is up to your choice. I prefer the AGV here. Advantages is that you're getting an IOP reduction in a complex glaucoma case along with a visual rehabilitation. The complications are the same as for tubes: the exposure, the hypotony, corneal endothelial loss, and diplopia. Both the TVT as well as the PTVT study do say that you can go ahead with the combined surgery having a tube along with the cataract. So do remember, take home phaco and trap for your moderate and advanced cases, phaco and mix when you have mild to moderate cases, phaco and tubes for your refractory glaucomas. Thank you.
Thank you, Dr. Sandhya. We'll have the discussions later, okay, because we are running. The next speaker is going to be Dr. Priyank Solanki. He is the Joint Secretary now and going to take over as the Treasurer of Bangalore Ophthalmic Society. He will be talking to us about management of cataract in post-refractive surgery eyes. Dr. Priyank.
Thank you. So good afternoon everyone, and at the outside I thank AIOS, POS and Dr. Elan for giving the opportunity to be on this stage. So I'll be talking to you about on cataract surgery in post-refractive eyes, specifically regarding the cornea part. Now, in today's day cataract surgery, it's no more just a vision correcting surgery. It's more of a vision correcting plus a refractive surgery. Now, you need to know which kind of patients which are going to be treating now and in the next decade. Okay? So, the difference between these two, the millennials and the Gen Zs, are quite a bit. Okay, most of us would be in the millennials groups, and now they are going to come to us in this present decade or the next decade for this. So you need to be ready and knowledgeable about this procedure. So maybe 10 years back, our regular OPD was 60, 70 plus people aged who are used to come for cataract. But now we see a lot of people coming at 50 and saying that I want to be glass free. Now most of this people would also have one of the other refractive surgeries done. So the background of my presentation will be IOL presentation after cataract surgery is challenging because standard IOL power formula can lead to significant unintended post-operative refractive errors. Understanding the present scenario of these formulae and need to understand the predictable outcomes after these surgeries. So I will be covering three major parts, which is the post-LASIK and post-PRKs, post-RKs, and a part of phakic IOLs. Now, what you should understand is the basic understanding is that the standard corneal power measurements are done by the anterior topography, means anterior corneal surface, which affects your effective lens position of the placement after the surgery. So, keratometry error is not noticed after the LASIK surgery. So when you are calculating your lens power, you should know these 2 points. First, after laser vision correction, the anterior corneal curvature is modified, but the posterior surface is not changed. So you can see here that the normal anterior and posterior corneal surface is there. Whereas after an anterior surface procedure like LASIK or PRK, the anterior surface is flattened, but the posterior surface is not flattened. So your anterior to posterior ratio is modified. Same thing happens in radial keratotomy cases where the anterior posterior surface in normal is similar, but the posterior also gets pulled up because of the scarring which happens in these cases. So these two factors have to be considered while doing your IOL power calculations. Now, in standard IOL formulae, the use of axial length and corneal power to predict the positions of the IOL. Whereas refractive surgeries of both PRK or LASIK would change the corneal power and hence your effective lens position. So after a myopic correction, you will see that the corneal power is decreased, hence the ELP is lower. Whereas in a hyperopic LASIK, your corneal power is higher because it makes it steeper, hence the ELP becomes higher. So, an altered corneal curvature will cause an error in corneal power and imperfection in predicting the effective lens position. So, post-myopic surgery, you will underestimate the IOL power, whereas in post-hyperopic surgery, you will overestimate the IOL power. So this is basic that you should understand. So post-operative surprises happen because of this unknowingly. So how do we measure this? True cornea power. So you have a gamut of machines now which helps you to do this. Now you have to find these machines either like Pentacam, OpScan or Galilei, where you will have OCT based technology or shine plug based technology. Now the formula that you should use. First, double K formula, which is one of the most commonly used and which is the most accurate one. Hofer Q and Hackey's are the other two formulas. We also have the Barrett True K formula, but you need to have the pre-op surgery values also. Now, so after knowing what is the lens to be used, power to be used, now you should decide, do you want to use a spherical lens or aspherical lens, a toric or not, or a multifocal or a monofocal lenses. Now, for this you should know what a spherical aberration is. Now, by nature, by development, your cornea is positively spherical and the lens is negative spherical. Now with age, what happens is the lens changes its sphericity. Hence, you will see that more positivity with age. So an increased spherical aberration will cause a reduced visual function, reduced contrast sensitivity and halos around. So what happens in a spherical aberration is your Strum's choroid is expanded. Whereas in aspheric, it becomes a bit more, point focus. Hence, you see more clear, more sharp, more brighter. Now, so a cornea with a positive spherical aberration, when you see here the Z40, okay, you use a negative spherical ion. Whereas in a cornea negative spherical aberration, you use a no negative, means you don't have a positive per se, it's only a spherical lens. So this slide will help you understand. Post LASIK, if it's a myopic LASIK, the cornea is oblate, hence there will be a positive spherical aberration and you use a negative spherical aberration lens. In a hyperopic LASIK, your cornea is prolate, hence you will use a negative spherical aberration lens like a basically spherical lens, because all of these are plus spherical. So these are the few common lenses which we generally use in practice. So Zeiss, Hoya, IQ, Acreon are all negative, the highest being the Technics. So based on your corneal topography, spherical aberration, choose your lenses so that you can give the best possible outcome for your patients. Now, coming to this RK, here you should understand that how many scars are there, how many incisions are there, and how is the cornea responding or reacting. If there are less scars, like 4 or 6, then you can do a clear cornea. Whereas if you have more than 12, then try to go for a limbal or corneal, scleral. So that will give less stress onto your scars. Now, post-phakic cases, there are only two options you have. Either you remove the lens and cataract in one sitting and implant the lens immediately. Second scenario is you remove the ICL, wait for about a month or two for the cornea to stabilize and then implant. Most of the time, what we generally do is the first scenario where the outcomes are also excellent, because most of these cases the powers are -10, -12, -14, they would be 6.9 or 6.12. Then post-operative, they definitely come up to that. The chances of having a residual refractive error in these cases are lesser because you're giving a higher power lenses. Right? So the take-home messages in this are: first, understand what the patient wants. Second, understand what the situation of the eye is, whether it's post-myopic, post-hyperopic, post-RK, and there are any other scars in the cornea. Choose the right procedure and the IOL based on the investigations. Just because the patient has heard trifocal lens, EDOF lenses, don't go for them directly because they might not be suitable for his lenses, for his eyes, or an aspheric lens. I have got Alcon lenses, I want these lenses. No, you say that with the investigations, I see that this is advisable and hence this is what is advisable. Second, cross-verify the IOL power if with the available formulas. You choose, you have ACRS calculators, you have Barrett K formulas, you have TrueNet formulas, double K formulas. Try to get the maximum information from the patient also if he has the previous topography reports or previous biometry reports. So these also will help you. In our center, we have practiced that topo means before LASIK also, before ICL or phakic, we do a biometry of the patient and give a copy to him so that he also has a copy for the next 15-20 years if he has one, okay, hard copy. But the soft copy is always there. So the patient comes even after 10 years, we can give him that reports for his future evaluations. So these are things what you should understand. Okay? And always under promise and over deliver. Do not say that you will give the best possible outcome. You say that I'm going to give you the realistic outcome rather than what your expected outcomes are. Because the reality is what I know, expectations are always sky high. Okay? Thank you.
Next, I would like to invite the chief instructor of this session, Dr. Alan Kumar Pasupati. He is the president of Bangalore Ophthalmological Society and is currently the joint treasurer of the AIOC and is a prolific surgeon and a very good orator. So, Dr. Alan Kumar.
Thank you, sir. At the outset, I would like to thank the scientific committee and Dr. Namrata Sharma, madam, for giving us this opportunity. Topic for today is going to be management of dry eyes with cataract. I'm sure those of you who have come in a little bit late would be wondering. We started this session more than an hour late, so we'll try to finish it as early as possible. What is this? When I started my post-graduation or residency, this is what we were taught. Dry eye happens in almost all cases of cataract surgery, starts on the first day of cataract surgery, increases till around 1 week, continues to stay for at least 1 to 1.5 months, and then reduces. So why so much of fuss about all these things? It was these two papers which were released somewhere in 2015, 2016, around that time. So what did these two papers say? Almost 85% of those presenting with cataract and dry eyes don't even know that they have dry eyes. This is the problem. These are the patients who will go for advanced IOLs. They'll come back and then they're going to create trouble for us. Now it is for this reason that an algorithm which is consensus and evidence-based, which reduces the chair time of a surgeon, can be easily incorporated into practice and it can be classified into visually significant or not, so that the IOL problems are avoided, IOL power calculations, poor post-operative vision quality is avoided, and sometimes rarely these kind of infections are avoided because of dry eyes. Now this particular talk is divided into pre-operative, perioperative, post-operative and other things that are going to be used. Pre-operatively, what is the single most thing that has to be done? It is this algorithm given by ASCRS. ASCRS is a surgical society, but they gave a medical algorithm for those patients undergoing cataract surgery. What is this? This is an algorithm, non-invasive, can be repeated if necessary, and most importantly, it is an idiot-proof algorithm which even your receptionist, forget about your optometrist, can do it sitting in his chair. How does it start? As soon as the patient comes for cataract surgery, do his IOL measurements. This is the first important thing, because IOL measurements change even with applanation tension or sometimes with NCT also. Followed by that, while doing the IOL measurement, ask your optometrist to check for any change of Myers, or in the printout, look for this inferior steepening. If these kind of things are there without any other problem, this is a case of dry eye. Next thing what you do is, when the patient is sitting outside, give him a questionnaire. Now ASCRS suggested a speed 2 questionnaire, but what I use in my practice is a OSDI questionnaire. Doesn't matter which questionnaire you use, but be sure that you are well accustomed to that questionnaire and can interpret it properly. Next, they asked to go in for symptoms. Along with that, look at osmolarity and inflammatory markers. Now let's remember, in private practice this is impossible, as well as osmolarity is something which we do not use. So instead, what I would like to do is just look for the aqueous, that distance. Normally it should be around 0.1 to 0.25 millimeter, either less, either more is a problem. Look at the mybograph. Mybography, if you do not have, you can just use an autorefractor and see the meibomian glands. That will help to a major extent. Then you do this lift, look, lift, pull and push. Look for any abnormality, lift the lid and see what is there beneath, pull the lid to look for laxity, push the lid to see for meibum secretions, and then also look for any kind of staining, or you can say this, Lipkoff folds. Conjunctivochalasis is the normal word we use. This also can cause dry eye. If any of these are there, particularly if these two things are there, any staining or Myers which are changing, power which is changing, keratometry which is changing with every blink, then you classify it as visually significant. If it is not there, visually non-significant. If the person doesn't have any dry eyes, then or non-visually significant dry eye, directly go ahead with the surgery. If he has visually significant, then you will have to wait for some time. How much is this some time? Ideally, it should be 4 to 6 weeks. Treat him, repeat all these tests, and then take him up for cataract surgery. That's what is advisable. But in Indian scenario, if you let this patient, he will metastasis in the nearest possible cataract clinic. So better to first collect something from him and then do it. Now, there are various machines available to check for dry eyes in the market. These are the machines, but I prefer for a practitioner tear check. I have no financial interest. Only advantage with the tear check is looks for maximum possible readings acceptable. Now, peroperatively, what should we do? This is a new term called STODS, Surgical Temporary Ocular Discomfort Syndrome. And in this, without going into the details, cataract surgery is one surgery which has 4 different mechanisms by which it causes dry eye. So very important to rule out dry eye in case of cataract surgeries. And you'll be surprised to find that flax has more incident than traditional cataract surgery when compared to dry eyes. Why is this? The reason is, we'll come to it in the next slide. Before that, any cataract surgery, there's an incisional corneal damage, ocular surface damage due to drops, phototoxicity, the surgical trauma, pulling of the conjunctiva, repeated irrigation and drying. Also, there are some epithelial cells that are lost. So, what should we do? As I said, flax, that's because of the use of suction ring, it destroys the glands. Now, repeated drying and irrigation can be reduced by using HPMC over the cornea. Eye drops, this is the dictum I follow, 2 drops of povidone, 1 drop of anesthetic, and no NSAIDs if possible, or minimum NSAIDs if possible. This is what I follow. Phototoxicity, reduce the time taken for surgery, reduce the surgical trauma, do not touch the conjunctiva, operated, and if possible, instead of the temporal incision, go either superiotemporally or inferiotemporally. That will help a lot. Now next, post-operatively, what should we do? Question is, should we use lubricating drops in all cases of cataract surgery? Without going into the details of this study, I'll tell you, 4 groups, the last group had lubricating drops, the rest of the groups had this. But look at the results, what was obtained. Everywhere, the 4th group did better. So, point to take home, use tear drops for all cases of cataract surgery. Which tear drop? We'll come to it later. When do we use cyclosporin? I use cyclosporin if there is a diagnosed visually significant dry eye in all my cataract cases. No dry eye, no visually significant, I do not use cyclosporin. So, teardrops whenever diagnosis is made, cyclosporin whenever dry eye is made. Now, this is something we fellows who are using dexamethasone and convert to prednisolone found out this. Dexamethasone caused more dry eyes. Prednisolone caused more dry eyes. So, we have a study to prove that. Again, if possible, go with dexamethasone. But then many of us still use prednisolone acetate, use as minimum as possible. As regards NSAIDs, there's an evolving trend that we are using less and less of steroids and more of NSAIDs. That's okay, but stick to NSAIDs once daily or twice daily, not more than that. And wherever there is a threat of dry eyes, try to stop using the NSAIDs. Now, next, what do we do? Follow what is told in DUCE 2. Now, there is a DUCE 3 also. And all patients check for dry eyes. That's what it says. And this is the most important slide, what I would like to mention. If the patient has grade 1, treat him as grade 2 if he is undergoing surgery. Grade 2, treat him as grade 3. Always we used to introduce cyclosporin in grade 2. That's why I said use cyclosporin whenever a diagnosis of visually significant dry eye is made. This is the reason I told that. There are various nomograms to treat dry eyes. Follow them. And next question. I'm a practitioner. I do not have any of these machines. What should I do? Beautiful study by Asia Pacific Dry Eye Society. Even with a simple fluorescein, you can diagnose dry eye. Look at what type of dry eye this is and then treat these patients. Do not hesitate to treat these patients. Again, if you do not have a mybographer, you can always use your autorefractor. Yeah, sorry, I'm for the last 2 slides. Next talk is also mine. treat the meibomian glands, and which is the drop to be used. In all cases, we use artificial tears. Which is the one drop to be used? Which is the drop that you see maximum action? It's hyaluronic acid. Again, that's what is reflected in this study, in this article, also second article. So I prefer hyaluronic acid as the treatment for dry eyes in all my cases of cataract surgery. This is the first talk. This is the second talk, management of pterygium with cataract surgery. Sir, I'd like to go to that directly. Thank you once again for the opportunity. Simple talks, why should we keep talking about it? But this is what we face maximum in our practice. That's why this IC was made for that. Nowadays, cataract surgery has become more of a refractive surgery with the advent of toric, trifocal lenses. So it has the precision, it needs the precision of a refractive surgery. And add to this, we have created this problem with the patient, induced high patient expectations. So cataract surgery, in case of pterygium, we should be very careful. What does pterygium cause? Increase in astigmatism, decreases the curvature of the cornea, corneal flattening, and very importantly, induces aberration. All three are dangerous for IOL power calculation as well as the results that we obtain with cataract surgery. Hence, the need to look at all these things. What are the two things that we have to look at? Number one, what is the type of surgery that we are going to do, technique, and what is the timing of this surgery? These are the two things I'm going to talk about. I'm not going to show any particular videos. Most important point I would like to say is stabilize this cornea before you start operating for cataract. So what are the 6 things which we may look at it? Is there a visual axis invasion? Then the management is different. Is there a corneal topography distortion? Is there a corneal flattening? Is there very severe astigmatism? Look at the aberrations. Many of us miss this out. Are there refractive changes? These are the 6 points that we have to consider while looking at a pterygium. Now, what happens with a large pterygium? Corneal flattening, dryness increases, abnormal curve pattern, and remember the last thing what I have written here, reversal is difficulty. Despite doing your pterygium surgery, many times it does not reverse. So what is the take home point? If you are doing an advanced IOLs, multifocal, trifocal, EDOF or whatever it is, you will have to do an extra corneal procedure with this large pterygium. Larger pterygia, more chances of flattening and corneal changes. Now post pterygium removal, there are 2 things that can happen. One, corneal aberration can further deteriorate because of the healing, because of the opacity. Severe astigmatism induction can happen. So always have these 2 points. How long does these changes last? Now for anything to be treated, it has to be stable. How long does it last? Studies reveal at least 1 year. There are various things you will hear 3 months, 6 months, but at least 1 year, both refraction, visual disturbance because of aberration, it changes. So when we have to take a treatment decision, size of the pterygium matters, visual impact, distortion and topographic changes. Based on this, decide when your surgical timing is, whether it's sequential or simultaneous. Location, instead of temporal, we might have to shift to superior-temporal, sometimes even superior-nasal in case of large pterygiums. IOL calculation prediction depends on what kind of lens. Aberrations, Dr. Priyank was talking about in refractive surgery. Look at these aberrations before deciding what IOL to use for this. Question is, should it be sequential or simultaneous? Each one has its advantages. This is the ongoing debate. Sequential approach where you treat the pterygium first and then go for cataract surgery. Simultaneous, you do it together. Simple dictum what you can follow. If the pterygium is less than 2 millimeter, you can do simultaneous. More than 2 millimeter, go ahead with sequential pterygium surgery. This is what happens. 2 millimeter, almost nothing, no change in the thing. More than 2 millimeter, this is what happened. If visual, pupillary area is impeded by the pterygium, these are the changes. These are almost permanent changes. So here you do simultaneous, here you do sequential, and here you do sequential, but in between you will have to introduce a laser procedure for stabilizing this cornea or go in only for monofocals. This is the study I want to present. Astigmatism might become stable, not very significant after cataract surgery, not very significant, but look at what is happening to the aberrations. More than 2 millimeter significant, less than 2 millimeter not. And this stabilizes around 3 months. But then aberrations keep changing for more than 1 year, and all this p-value in this area is significant. Hence, 2 millimeter is the cutoff if you have to do simultaneous surgery or sequential surgery. Again, treatment flowchart less than 2 millimeter. Either you can do cataract surgery first if pterygium is not growing, or you can combine it. If it is a larger pterygium, okay, the problem with this, remember, again, if it is larger pterygium, it continues to distort the keratometry. So in these cases, cataract surgery should not be done first. It should be the pterygium surgery. Stabilize these things and then go ahead with the cataract surgery. What is the ideal stabilization period? We already spoke about that. 4 weeks to 3 months was what is said. But in cases of large pterygium, 1 year or 2 visits, 4 weeks apart, where the refraction, keratometry, as well as aberrations are stable. If it's for 4 weeks, we can take it up after 3 months. High patient expectations, but these are the factors. Size of the pterygium, recurrent pterygium, be very careful. Dry eyes, be very careful in using advanced lenses. Recommendations, if you're going for refractive procedure, trifocal IOL, toric IOL, EDOF IOLs, do this after 3 months to 1 year. If you're going for a spectacle prescription, of course, you can go ahead a little bit earlier. What are the benefits of simultaneous surgery? One biggest benefit is saves time and energy for a surgeon. In India, with large thing, we can manage, but then there are a lot of disadvantages. Given an option, I would like to do sequential surgery because simultaneous surgery causes myopic shift, more of corneal steepening, might require use of antimetabolites, which is nowadays not used, longer use of steroids, and of course because of the size. So sequential is a preferred surgery. Obvious reasons. Last 2 slides, please. Pterygium excision first, wait for corneal stabilization, proceed with cataract surgery, wait for stabilization period, larger pterygium. Recurrence, all of us know that AMT and limbal autograft have the same chances of recurrence. So either one of them can be used depending on what you get. And the obvious advantages with AMT, autoconjunctival graft, all of us know. So if you are doing a simultaneous surgery, go for watertight incision, suture placement properly, temporal approach if possible. If not, you can shift to the superior approach, less cauterization, use the corneal ports properly, avoid toric IOLs if there is no stabilization, standard monofocal IOL. Prevention of complications, very important. If you follow all these things, then you may not get this. And then 2 millimeters, already we have told 2 millimeters is the cutoff. So cataract surgery, first if it is less than 2 millimeter, directly you can do it. If not, go ahead with pterygium surgery first. And then if you follow all these things, evidence-based approach, you will get away with problems. Thank you for the opportunity.
Thank you, Dr. Alan. Excellent talks. Both of the talks were excellent.
Sir, I would like you to take over the stage. Tips and tricks for anti-VEGF injections along with cataract. Dr. Subhash Prasad is currently the Vice President of Bihar Ophthalmic Society. He was a senior resident to my senior residents from Epicenter, large practice in Patna. Please go ahead, sir.
Thank you, Alan, for including me in this IC. Intravitreal injection is one of the most common ophthalmic procedures nowadays. Over more than 20 million injections being performed every year. And while it has revolutionized the treatment of retinal disorders, but at that same time they carry the rare risk of causing iatrogenic lens injuries. Thus the incidence are very low, but if you consider the absolute number of the injections, the actual numbers are actually very high. So there is always a risk of 2.3% as compared to the normal persons who have not undergone injection. The risk of hitting risk of posterior capsule rupture or jonular weakness in these patients. And the risk increases per injection. It has been calculated that 4% increase in risk is always there with the subsequent injections. And there are a lot of literatures available that has proved that the intravitreal injection is the single most important risk factors for posterior capsule tear in those patients who have undergone intravitreal injections. How does the lens injury occurs? It can be mechanical because of the mechanical touch of the needle or due to the high velocity impact of implants like Ojudex. Particularly seen in small eye or hyperomic patients, or nowadays even in the ROP patients, the intravitreal injections are being given. So those babies are at risk of having posterior capsule touch and subsequent cataract formation. Or there can be improper technique nowadays. Intravitreal injections are being given right and left everywhere, even though they are not taking proper measurements and other things, and sometimes patients are not very much cooperative. Once there is touch to the lens, the cataract may remain just static at the same spot, or it can progress. Sometimes it progresses very fast, particularly if the Ozurdex injection has been given. So how to prevent that? Every time one has to measure how much behind you are going to the limbus. So in phakic patient, it is always 4 millimeter that has to be followed. There should be perpendicular entry, needle direction should be towards the center of the globe, and the needle should be 30 gauge, not less than that. And then how do you work up these patients? So these patients will give history of decreased vision over hours to days once they give the history of intravitreal injection. But most of the time these patients have poor vision because of the retinal pathology. So there should be always a high clinical suspicion. If you find that the cataract has rapidly progressed after intravitreal injection, then you must suspect that probably the patient has developed cataract because of the hitting of the posterior capsule by the needle. These patients has to be carefully looked for sign of any lens touch with the needle. That can be there as a track, capsular track, focal opacity, or as a star-shaped rosette pattern. And if you are not able to see, or if just for documentation, you can do anterior segment oscillatory. That is very much helpful. And sometimes other gadgets can be used, like if the cataract is matured enough, you can do the B scan that will show the tear in the posterior capsule and some lens matter in the vitreous cavity also. So these are some of the clinical picture you can see here. The tear the patient underwent eccentric injection. This is the ASOCT picture. This is with the serious photographer I had, so I just took it. It's not necessary. And this is the B scan photo of the same patient. And this patient underwent Ozurdex induced posterior capsule tear, preoperatively seen with slit lamp, and then this is the ASOCT in B scan. So how should we approach these patients? So the question is when to operate. When the cataract is visually significant, it should be operated, and otherwise it might progress very fast. It's always preferable to do under peripheral anesthesia, keeping the vitrectomy set standby, and always treat it as you treat it a case of posterior polar cataract. You have to take all the precautions so that this tear doesn't allow vitreous to fall behind, the lens to fall behind into the vitreous cavity. So the dictum is no hydrodissection, do no nucleus rotation, rather you do the hydrodelineation and take a very slow motion phaco. You can inject the viscoelastic to cushion the posterior capsule and part of the nucleus, and always low parameter. If you don't have the active loading system, just decrease the bottle height and avoid HC fluctuation at any point of time. And as told, the vitrectomy set, this is one patient who had developed this touch, and this patient required, and this was a relatively young patient, so the nucleus was not very hard, and the patient had significant amount of astigmatism. So I thought that I will implant toric lens in this patient. Again, dictum is to do the surgery in a very controlled manner without letting the chamber fluctuate. Otherwise, this tear will extend, and you won't be able to implant the intended lens. You will have to use the 3-piece lens in the sulcus. So I went ahead carefully and managed it without any problem, always taking care that I don't allow the anterior chamber to fluctuate. And you can see the tear there. And again, before coming out, before removing the irrigation, one has to inflate the anterior chamber, and I am implanting the toric lens here. And the problem is that the alignment axis is almost nearly in the same direction where the tear is there. So even then there is good amount of support because this tear has not extended. So the lens was very much stable even after the surgery. Another case, you can see the tear here. Same thing, same principle has to be followed. Here hydrodelineation, no hydrodissection. But I was unfortunate to have PCR, and then just 1 minute. And then there was vitreous collapse also, so I managed it through the pars plana route. I'm using the bimanual irrigation aspiration and then trying to remove it gently and slowly. But here you can see the vitreous prolapsed into the anterior chamber. So not allowing to prolapse further, I am injecting viscoelastic through the side point and going into the pars plana to do the vitrectomy and remove all the cortex before I can implant 3-piece safely in the sulcus and doing the optic capture. So here I did not put single piece lens. I used the 3-piece. So always keep a standby 3-piece lenses in these patients. Even though you have planned something else, but always keep on a standby lens. So I'm putting this in the sulcus and then doing a capture and checking that there is no vitreous in the anterior chamber. Just last small video where I have actually.
Sir, you have 1 more minute. Don't worry. The timer here shows 1 more minute.
Yeah, yeah. Okay. So here I encountered the same problem, but I thought the nucleus was little softer, so I used the technique of IL scaffold. I implanted the multi-piece lens just behind the nucleus, and I did not dial the lens into the sulcus, but kept it over the iris, and the trailing heptage was outside. And it's not necessary that you always go through the pars plana route. You can use the limbal route very well, and that can also clear sufficient vitreous and sufficient cortex without any problem. So since I have exposure of doing this vitreous surgery also, so I'm more comfortable going through the pars plana route. So you can see some vitreous hemorrhage also, because this patient was recently given injection for diabetic vitreous hemorrhage and was planned surgery. So he developed cataract, and again checking the anterior chamber is very important so that there is no vitreous left. So with that, just to summarize that these problems can happen, and nowadays because a lot of injections are being given, so you will encounter some patients developing these types of problems. So you have to be prepared, you have to be very much vigilant, you have to identify these patients and take a surgical procedure which is very safe, like posterior polar cataract. And even if there is any problem with like this, you can get away if you manage it very well. So thank you very much.
Thank you, sir, for that beautiful presentation and very good videos. To those of you who are here, we started almost 1.5 hour late, actually. That's the thing. The next topic is going to be management of diabetic macular edema with cataract. Dr. Ashok Kumaran. He's a prolific surgeon from Pondicherry, and he's a visiting faculty at MGMC and RI, JECC PGRI. Dr. Ashok, you can talk about management of diabetic macular edema with cataract.
I thank Dr. Elan for giving me this opportunity. Now, a successful outcome in diabetic patients not only involves proper placement of intraocular lens, but also involves management of the diabetic macular edema to ensure a proper anatomy of the fovea. Now, in diabetic patients who undergo cataract surgery, it has been shown that even in the patients who have a normal macula, there is an upregulation of cytokines like interleukin-1 as well as VEGF, which usually take up to a month to decline to the preoperative level. This explains the usual problems in the diabetics face after cataract surgery. Now, there are three scenarios which I want to discuss. The first is where the patient presents with a normal macula. After cataract surgery, patient develops diabetic macular edema. Patient has got a pre-existing diabetic macular edema which worsens, and the third scenario, which is the cystoid macular edema, post-operative cystoid macular edema. Now, there are different opinions from different studies. Squirrel et al., Wagner et al. Have shown that uncomplicated phacoemulsification does not worsen diabetic retinopathy. As such, the worsening of diabetic retinopathy is only a natural course of progression. This is because of smaller incision size and lesser inflammation following phacoemulsification, which is uncomplicated. But other studies have shown that the risk ratio of new onset diabetic macular edema after phacoemulsification to be 1.8, and the risk ratio increases to 6 and above if there is a pre-existing diabetic retinopathy, which correlates with the severity of pre-existing diabetic retinopathy. Also, a cohort study from UK on 4,000 and above 4,000 eyes show that the risk of treatment requiring diabetic macular edema worsens or is aggravated. Usually the peak is around 3 to 6 months after the phacoemulsification. Another thing that was correlated was limited surgical experience or surgery done by residents were statistically associated with more retinopathy progression. Various intraoperative factors like PCR, iris chafing and other extensive manipulations can aggravate by worsening the cytokine level. Now, the various options to manage diabetic macular edema along with phacoemulsification are periocular injection of steroids in the form of subconjunctival triamcinolone or posterior subtenaneous or subtenaneous triamcinolone 20 to 40 milligrams. Or we can give intravitreal injection of a dexamethasone implant 0.7 milligrams. Or we can give intravitreal anti-VEGF. Now the first scenario when the patient has got there is no preoperative diabetic macular edema where the macula is normal. So that's usually the risk of diabetic macular edema in an uncomplicated phacoemulsification is quite less. So we manage with topical NSAIDs which can be safely continued up to 90 days post-operative period. But if the patient presents with a pre-existing diabetic macular edema, then there are three options which can be discussed. One is we do a phacoemulsification and then refer the patient for a management of diabetic macular edema. That actually worsens the diabetic macular edema because there will be delay in treatment, and so which should not be advised. So either we do the two things, where there's a simultaneous management of diabetic macular edema with phacoemulsification, or we stabilize diabetic macular edema and then do phaco. How do you go about that? Because based on the fundal view and to treat as well as the quality of life. If both are good, then we defer the cataract surgery and manage the diabetic macular edema by using anti-VEGF injections. We can combine with grid laser. Or if patient is visually rehabilitation has to be done immediately, then we have to go for a simultaneous injection. The simultaneous injection with phaco has got the advantages of a rapid rehabilitation and fixes both the problems for the patient. Now the injections used, intravitreal injections used are either anti-VEGF or injectable steroids. Various studies have established that anti-VEGFs are the gold standard in treatment of diabetic macular edema. The most common we use is ranibizumab. We follow the standard treat and extend regimen of 3 to 5 injections for monthly, followed by extend regimen. Now these are some clinical scenarios where you can see on the left side the pre-op OCT, and the right side around 1 month post-operative OCT showing decrease in macular edema following phaco with anti-VEGF. Intravitreal steroids, especially dexamethasone implant, have shown to be very effective in studies. That's because not only they block the VEGF effect but also the other cytokine effect. The most common used injectable steroid is intravitreal dexamethasone implant because of the advantage that it can retain its action up to 3 months. But the disadvantage is there is a significant elevation of IOP in up to 15 to 30% of patients. There can be up to 10 millimeter increase in the IOP. The other question is whether we inject the dexamethasone implant before phacoemulsification or at the end of phacoemulsification. That is because it is a 22 gauge system, not a 30 gauge delivery like intravitreal anti-VEGF. So there can be significant hypertonia after using intravitreal dexamethasone after phacoemulsification. The second thing is if there is a PC rent and if we inject dexamethasone implant, it can migrate into the antechamber and cause multiple problems. So that has to be done carefully and meticulously. Now these are some case scenarios where we have given dexamethasone implant after phacoemulsification showing a significant resolution of macular edema in the post-operative period. This last one is where patient has undergone a post-subtenon triamcinolone with a significant resolution. Now whether dexamethasone implant to give or anti-VEGF to give. Anti-VEGF is a gold standard, but dex implant scores over in patients who have OCT showing inflammatory biomarkers like highly reflective foci, subretinal fluid. Patients with ERM with the diabetic macular edema do well more with the dex implant. In vitrectomized eyes also. The other advantage is the fewer injections and so better compliance. But the IOP problem has to be kept in mind whenever we decide this. Lasers have become more of an adjunct, but we still use it because it reduces the need for anti-VEGF. If the media permits preoperatively, we can do focal or grid laser, or if media is AC, then we do it after 1 month. As far as PDR is concerned, pan-retinal photocoagulation should be done, and some surgeons, some authors say up to 1 year, but we should wait at least for 3 months for stabilization before proceeding for cataract surgery. Diabetic macular edema actually has got a good prognosis if we aggressively manage the diabetic macular edema whenever we perform cataract surgery, and studies have shown that very good outcome can be obtained even in patients with advanced diabetic macular edema. Now coming to the last part, that's post-operative cystoid macular edema. Now we have to differentiate a pseudophakic cystoid macular edema from a pre-existing worsening of pre-existing diabetic macular edema or a new DME. Both have different pathophysiologies and so two different treatment modalities. PCME is caused by cytokines and upregulation of cytokines and prostaglandins, and not by vascular occlusion. And the clinically what we see is there will be minimum diabetic retinopathy and more cystic spaces by OCT. So PCME is managed by topical NSAIDs with steroids and stepped up to injectable steroids, either subtenons or intravitreal steroids, depending upon the response. Now, pre-med study has shown that the peak incidence are around 5 weeks post-operatively, and combination of NSAIDs with the subconjunctival triamcinolone alone almost effectively prevented post-operative CME in patients who had diabetes who underwent phacoemulsification. Thank you.
Thank you, Dr. Ashok. Actually, we started around 4:08 or 4:09. Sir, we have finished 25 minutes ahead of time. Any questions you can ask us later because the session was running 1.5 hours late. So next session will start. Thank you.